Welcome to the Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm Dr. Andrew Wilner, and my guest today is Gene Sung. Welcome, Dr. Sung.
Hi.
Dr. Sung, you are the Director of Critical Care at LA County Hospital in Los Angeles, and you've been in this business a long time, and you are also the author of a paper that came out online in August about the World Brain Death Project's conclusions about brain death. And I read that paper word for word, and I really did. And I was impressed not only at its thoroughness, but the fact that you could actually get it done, because it's the World Brain Death Project. I mean, the whole idea is like get the whole world on board, and just getting the department on board is it's usually a big deal. So, as department chairman, that's what you do. So you really used your skills. So I want you to tell us a little bit about your background and how you got involved in this topic of brain death. And what did the World Brain Death Project accomplish?
Sure. So I guess if you really want to know the real origins of interest in end-of-life care and brain death, was actually as a medical student, one of my neurology mentors was very interested in brain death and persistent vegetative state. He was a neurologist and a bioethicist, a guy named Ron Cranford from Hennepin County Medical Center, your both of our old stomping grounds. And he had been very involved in some of the persistent vegetative state cases that were going on, like in Florida and elsewhere. And so that's how I started sort of the academic interest in end of life, and particularly sort of the end of brain functioning. The more recent history for this World Brain Death Project is that actually, if my shirt, the Neurocritical Care Society. So as I was becoming as incoming president of the Neurocritical Care Society, I had decided that one of my big projects as president would be to help try to standardize the determination of brain death. However, that's a little over 10 years ago. However, I found out that as I was starting this project, that the World Health Organization, WHO, was actually doing very similar things. So of course I stepped aside and said, well, if the WHO is doing that, we'll certainly let them take the lead. And we were just a part of that project, but unfortunately it didn't come out as many of us had hoped. And so 5 years ago, I started this project once again, and this time taking the sort of the tact that the determination of brain death is a clinical practice issue. And so the major societies, the world federations of intensive care, pediatric intensive care, neurology and neurosurgery, the main practitioners who determine brain death, those world federations would be the backbone for this sort of consensus statement for how to determine brain death. That's how the project came about.
Well, why is it so important that everybody do it the same way? Let's start with that. I mean, sure. You can do it this way or that way, but pretty much, is it that hard to tell if somebody's dead or not?
Well, it's certainly, in one of my stock lectures that I give for the medical students, I think that certainly, and actually, in this day and age, there seems to be a real backlash against science among certain circles and against experts and in many different areas. And certainly, I think always someone wants to know if your doc is actually declaring someone dead properly or not. so we don't want to make any mistakes, certainly in this particular issue, in whether someone's dead or alive, whether it's, again, the more standard cardiorespiratory means of declaring someone dead or with brain death. And I think that one of the problems of having different means of determining brain death or different protocols or different guidelines is that it brings about some uncertainty in that if you can be declared dead in one state but not another, that doesn't quite make sense to a lot of people, understandably, I think. And so we are hoping that we could try to minimize the differences somewhat throughout the world, because there are lots of differences. And if we could at least try to, that was our main goal, to try to minimize the differences, but also to make this sort of a foundation for sort of everything we know about brain death at this point in time.
I'm going to step back for a minute because all of the viewers are not physicians. And this really goes back to the time when, you know, if you were dead 50 years ago, you stopped breathing and your heart stopped and you were dead, and there was complete agreement and no debate. There usually wasn't an issue. But once people started being maintained on life support where the machine could breathe for you, then it wasn't so clear. So in 1968, there was the Harvard criteria where they came up with sort of the first formal brain death criteria. And those have evolved over time. And I bring it up because I want to ask you about that. One of the aspects of the Harvard criteria that I didn't see in the world brain death criteria was the necessity for 2 examinations 24 hours apart. And people have asked me about that. And it's like, well, why do you need 2 exams? And it's like, well, I don't know. Is it because you weren't really sure the first time? I don't really know, you know. Right. And if I read this correctly, the World Brain Death criteria, which are very similar, I think, to the American Academy criteria of brain death, yes, it does not require 2 examinations or 2 physicians. Is that correct?
Yes, that's correct. So there, it's a little bit about certainty again. So back then, 50 years ago, over 50 years ago, to be absolutely certain, the group that made the Harvard criteria decided they would use that 24-hour standard. Since then, of course, there have been many, many brain death declarations and people studying brain death. And they found that actually doing 1 exam correctly seems to be sufficient. In fact, there was one study of New York State of over 1,200 consecutive brain death declarations, and they saw that if the first one was positive for brain death, the second one was always positive for brain death as well. So that really just doing it once correctly was sufficient.
Yeah, I think so. Now, the American Academy of Neurology in 1995 set up their own criteria. And in 2010, they revised them very minimally. And they said at that time that there's never been anyone who was pronounced brain dead using these very strict criteria with absence of brainstem signs and no spontaneous breathing with an apnea test, and so on, who woke up. It just doesn't happen.
Yes.
Because I think one of the problems that people say, well, what if there's a miracle, you know, but there's never been a miracle when these criteria have been applied. Is that correct?
That's correct. So every once in a while in the literature, you might find an unusual report, but when it's really looked at closely, though it seems clear that the initial brain death determination was not done correctly, or certainly not with the standards that we use here in the US.
Yeah, so right, because you read these articles, but then you find out, well, that person, they say came out of a coma. Well, what did they really mean by that? Was it
Right.
A minimally conscious state or a vegetative state? But they weren't brain dead. And usually the newspaper articles and the TV shows don't really get that nitty gritty, with all of the criteria. So what do physicians need to know about world brain death, this new paper that's bringing everybody on board? Are we going to be doing anything differently?
Well, probably not in the US. So I think that in the US and in many Western countries, we've been doing brain death determinations for quite some time and have developed fairly similar protocols throughout the years. And in fact, the World Brain Death Project protocols aren't that significantly different from the American Academy of Neurology latest guidelines from 2010, from 10 years ago. There's some very slight differences, but nothing, certainly nothing major, which also shows you, I think, the strength of clinical brain death determination, that really the pathophysiology and the clinical examination really haven't changed a whole lot. And so if you're doing it properly, I would think actually the only things that are different really are excluding confounders. So certainly there are more and more different situations that arise that weren't around previously. More different types of drugs, for instance, different understanding, and then now particularly the use of hypothermia after cardiac arrest is a new therapy, which does make things a little bit different in how we determine brain death. Excuse me.
So last question is, how did you get all these people with different languages and different cultures to actually agree?
Yeah, so that was certainly, it was interesting. The hardest part of this was getting the different world federations and all the different affiliated societies to get to work together to agree that those, first of all, that those is an important project to do together. But then they were asked to submit names of their members to help develop this project. And so, as it turned out, the people who were actually involved in the project didn't have that many disagreements at all. And so the people who actually practice brain death and teach and research brain death the most actually had quite a great deal of understanding and agreement with each other. And it was actually just getting it started to get the societies to agree to work together. And so it certainly took some time to get everyone together, to get we have 45 different named authors in this project. And then of course, after the writing of the project and editing of it, it has to go back to the societies to get endorsement. So that's what took a lot of time for sure.
And it has been endorsed by the American Academy of Neurology as well, isn't that right?
Yes. Well, there are a few societies, such as the American Academy of Neurology, that they have. They use a specific word, endorsement, only for very evidence-based guidelines, and so there is not a whole lot of, randomized controlled trials of how to do brain death determination. So they use another term, which is they affirm the educational value of this. So
Well,
that's
they're on board.
but they're on board.
You're on board. Well, Dr. Sung, I want to thank you very much for enlightening us about the hard work that you and those in 45 other countries have done to put this together so that we have uniformity and remove some doubt and increase confidence in when we do pronounce brain death as such a serious matter. Thank you.
Thank you very much for this opportunity.